Swayam Prabha. Digital India. Educated India.
I am Dr. K. Aparna Vedapriya, in charge professor and head of the Department of Anatomy at Osmania Medical College, Hyderabad. Today we are going to deal about 3, 4, 6 cranial nerves, which are the oculomotor, the trochlear and the abducens nerves. Before we enter into the topic, if a patient complains of double vision, and if you look at his eyes, when one eye is normal looking straight and the other eye looks to the side or to the inside of the eye, above or below, why does this happen so? Why and how these symptoms occur are dealt in the following class, dealing with the oculomotor, trochlear and abducens nerves in detail. So, the overview of these 3 nerves, the oculomotor, trochlear and abducens nerves, the oculomotor nerve, which has its nucleus in the midbrain, supplies the all extraocular muscles of the eyeball along with levator palpebrae superioris, except the superior oblique and the lateral rectus. It also conveys the parasympathetic fibers to the ciliaris muscle and the pupillary constrictor muscle for accommodation and the constriction of the pupil. The trochlear nerve, the nucleus is also in the midbrain, and the peculiarity of this nerve is this is the only nerve which exits from the dorsal surface of the midbrain and has true decussation. This nerve supplies the superior oblique muscle which moves the eye medially and downwards. The abducens nerve, the nucleus of which is in the lower pons, moves the eye laterally, which supplies the lateral rectus. Before we go into detail of these nerves, we should know how all these nerves are entering into the orbit. So, all these nerves, they enter into the orbit via the superior orbital fissure. This superior orbital fissure is divided into 3 compartments by a tendinous ring of Zinn, which gives origin to all the 4 recti muscles. So, from the lateral compartment of the superior orbital fissure, the lacrimal nerve, the frontal nerve, the branches of the ophthalmic nerve and the trochlear nerve gain their entry into the orbit, accompanied by superior ophthalmic vein. Through the tendinous ring, the upper and lower divisions of the oculomotor nerve, which are separated by nasociliary nerve, and also the abducens nerve, have their entry into the orbit for their supply. The medial most compartment is occupied by inferior ophthalmic vein, which has its entry into the orbit. So, once they enter into the orbit, this is how they look in the orbit for their destination. So, this is the tendinous ring of Zinn, which is giving origin to all the 4 recti muscles. So, from the lateral compartment, this is the trochlear nerve, which is supplying the superior oblique muscle only. So, the upper division of oculomotor nerve supplies the superior rectus and the levator palpebrae superioris. The inferior division of the oculomotor nerve supplies the medial rectus, the inferior rectus and the inferior oblique. The abducens nerve which is between the upper and lower divisions of the oculomotor nerve, supplies the muscle, the lateral rectus only. So, coming to the detailing of the oculomotor nerve. The oculomotor nerve is entirely a motor nerve which supplies levator palpebrae superioris and all other extraocular muscles of the eye except the lateral rectus and superior oblique. It also innervates the sphincter pupillae and ciliaris muscles of the lens by the parasympathetic fibers which it carries from the Edinger-Westphal nucleus. So, the functional components of the oculomotor nerve are, it mainly carries the somatic efferent fibers which is concerned with the movements of the eyeball. The somatic efferent column is in line with the trochlear nerve, the abducens nerve and the 12th cranial nerve also. It also carries general visceral efferent fibers which are responsible for accommodation and the contraction of the pupil via the parasympathetic fibers. The proprioception fibers from the extraocular muscles are carried along by this oculomotor nerve, in turn relaying into the ophthalmic nerve and then into the mesencephalic nucleus of the trigeminal nerve. So, this oculomotor nerve has its origin from the oculomotor nucleus. So, this oculomotor nucleus is a complex nucleus which is ventromedial to periaqueductal grey matter of midbrain, which is at the level of superior colliculus. All the nuclear components has ipsilateral supply except the midline nucleus which supply bilaterally. So, the caudal central nucleus gives its fibers to levator palpebrae superioris of both sides. The raphe nucleus gives its fibers to the superior rectus of both the sides, and the dorsal lateral nucleus gives its supply to the inferior rectus of the same side. Intermediate nucleus gives its supply to the inferior oblique of the same side. Ventromedial nucleus gives its fibers to the medial rectus of the same side. And the Edinger-Westphal nucleus, which gives the preganglionic fibers of the parasympathetic fibers, are relayed in the ciliary ganglion. The postganglionic fibers from the ciliary ganglion in the form of short and long ciliary nerves are supplying the ciliaris muscle and the sphincter pupillae muscle, which is responsible for the accommodation and the sphincter action, constriction. Coming to the deep origin of the oculomotor nucleus, the oculomotor nucleus is ventromedial to the aqueduct of the grey matter at the superior colliculus level. All the nuclear components have ipsilateral supply except the midline nucleus, which have its bilateral supply. The central connections are the corticonuclear fibers from the motor cortex of the both cerebral hemispheres are relayed into both the oculomotor nuclear complex, and it has connections from the medial longitudinal fasciculus, which also in turn connects with the 4th, 6th, 8th cranial nerves for the coordination movements of the eyeball. It also has connections from the tectobulbar tract, which connects visual cortex and the superior colliculus, which is responsible for visuoprotective reflex. And it also has connections from the pretectal nucleus, which is concerned with the direct consensual reflex. So, from the origin, there are about 12 to 15 fibers of the oculomotor nerve. They arise and they pass through the tegmentum of the midbrain via the red nucleus and the medial aspect of the substantia nigra and appear through the oculomotor sulcus, having the convexity laterally all through its course. After entering into the oculomotor sulcus, it is seen in the interpeduncular fossa, which passes between the posterior cerebral and superior cerebellar arteries, and lateral to the posterior clinoid process, it enters into the cavernous sinus and then divides into two rami, which enters into the superior orbital fissure through the tendinous ring. So, in the cavernous sinus, the oculomotor nerve is related to the trochlear nerve just above to that nerve. And the superior ramus, as it enters into the orbit, is lateral to the optic nerve supplying the superior rectus and the levator palpebrae superioris. And the inferior ramus of the oculomotor nerve divides into three branches, which supplies the medial rectus, the inferior rectus, and also the inferior oblique. A branch from the inferior oblique is relayed into the ciliary ganglion, which carries the parasympathetic fibers of the Edinger-Westphal nucleus, and the ciliary ganglion is present between the lateral rectus and the optic nerve. So, the communications of the oculomotor nerve in the cavernous sinus by the sympathetic plexus around the internal carotid artery, and in the orbit it is to the ciliary ganglion, and also it carries proprioceptive senses from the all extraocular muscles to the ophthalmic nerve. So, what happens if there is any injury to the oculomotor nerve? So, when general somatic efferent fibers are damaged, it leads to external ophthalmoplegia. That means the paralysis of extraocular muscles. When general visceral efferent component is damaged, it leads to internal ophthalmoplegia, which is the loss of accommodation, and mydriasis, that is the dilatation of the pupil. So, these ophthalmoplegia can occur due to Weber's syndrome, Benedict syndrome, whenever there is increased intracranial pressure. When there is increased intracranial pressure, the brainstem is moved down so that there is uncal herniation. With that, there is ipsilateral third nerve palsy and contralateral hemianopia, because there is compression of the posterior cerebral artery, which also supplies the visual area of the occipital cortex, and also causes ipsilateral hemiplegia, because the crus cerebri also is involved. And in multiple sclerosis also the third nerve palsy is seen. Because of the aneurysm of the posterior communicating artery also, there can be compression of the oculomotor nerve, because it passes between the superior cerebellar artery and the posterior cerebral artery. And in the diabetes mellitus and the hypertension also, the external ophthalmoplegia is seen because of the microvasculature, where the vessels are supplying the interior of the nerve, which carries the general somatic efferent fibers. When you look at the nerve, the central part of the nerve carries the somatic efferent fibers, and the periphery of the nerve carries the general visceral efferent fibers. That is the reason whenever there is compression of the nerve, first there is loss of accommodation and there is mydriasis. Then in this cavernous sinus thrombosis also may lead to third cranial nerve palsy. And keratico-cavernous fistula, when there is a rupture of the internal carotid artery, there can be keratico-cavernous fistula that can occur and compress the third cranial nerve, and there may be direct trauma to the third cranial nerve as well, and the internal carotid artery aneurysm, since the internal carotid artery is within the cavernous sinus. So, how does this oculomotor nerve lesion present? The lesion presents with the lateral squint and there is diplopia. The lateral squint is because of the unopposed action of the lateral rectus, because all other extraocular muscles have got paralyzed except for the superior oblique and the lateral rectus, which are responsible for the abduction of the eyeball, depression of the eyeball and intorsion of the eyeball are seen. So, there is drooping of the eyelid also that is seen, which is called as ptosis, because the levator palpebrae superioris is responsible for lifting of the eyelid and is paralyzed. And proptosis, that is forward bulging of the eyeball, is also seen because most of the extraocular muscles are paralyzed and they loosen the eyeball in the orbital socket. That is the reason there is proptosis of the eyeball also is seen. So, this is how the presentation is when the oculomotor nerve, as it is supplying all the extraocular muscles, when all these muscles are paralyzed, there is no proper strength to keep the eyeball in the socket. So, there is proptosis, and because of the unopposed action of the lateral rectus and the superior oblique, the eye is down and out. This is how is the presentation of the oculomotor nerve lesion, accompanied by the ptosis, and there is mydriasis because of the paralysis of the sphincter pupillae muscle. So, there is dilatation of the pupil that is seen. In Weber syndrome, it is mainly due to the obstruction of the posterior cerebral artery, and this causes the ipsilateral paralysis of the eye muscles because of the involvement of the oculomotor nerve, and contralateral hemiplegia because of the involvement of the crus cerebri. And for the Benedict syndrome, there is ipsilateral third nerve palsy because of the involvement of the third cranial nerve, the oculomotor nerve, and contralateral loss of sensation and proprioception because of the involvement of the medial lemniscus, and there is contralateral hemiataxia, that is the tremors that are seen because of the involvement of the red nucleus mainly to the upper limb, and there is contralateral hemiplegia as well because of the involvement of the crus cerebri. Now, to come along with the summary of the oculomotor nerve. The oculomotor nerve is taking origin from the oculomotor nuclear complex, which gives somatic efferent fibers and general visceral efferent fibers, which are the parasympathetic fibers from the Edinger-Westphal nucleus. Both form a single trunk, enter into the orbit through the tendinous ring of Zinn, and divide into upper and lower rami. The superior rami supply the superior rectus and the levator palpebrae superioris. The lower rami or the inferior rami supplies the inferior rectus, the medial rectus and the inferior oblique. The inferior rami conveys the parasympathetic fibers to the ciliary ganglion, which is between the lateral rectus and the optic nerve, and from the ciliary ganglion the short ciliary and long ciliary nerves, they pass between the choroid and sclera and supply the sphincter pupillae muscle and the ciliaris muscle, which are responsible for the sphincteric action and the accommodation. Now coming to the trochlear nerve. The trochlear nerve again is purely a motor nerve and supplies superior oblique muscle only. The nerve is named as trochlear nerve because the superior oblique muscle takes a bend at the bone of the orbit, which is called as trochlea. That is the reason the trochlear nerve, since it is supplying superior oblique muscle, has got its name as trochlear nerve. And this is a crossed nerve which has a true decussation and is the only cranial nerve which is exiting from the dorsal aspect of the midbrain at inferior colliculus level. This is the smallest nerve but has the longest intracranial course. It is the only cranial nerve to emerge from the dorsal aspect of the midbrain. Coming to the functional components, it has only the somatic efferent component, which is concerned with the movement of the eyeball because it also is arising from the preauric somoids, which is in line with the oculomotor and abducens nerves. Also carries proprioceptive impulses from the superior oblique muscle to the mesencephalic nucleus of the trigeminal nerve via the ophthalmic nerve. The deep origin of the nerve is from the nucleus of the trochlear nerve is at the floor of the aqueduct at the inferior colliculus level. So, the central connections for the trochlear nucleus are from both the cerebral cortex, and it also has connections from the medial longitudinal fasciculus along with 3rd, 6th and 8th cranial nerves to have coordination of eye movements. It has connections with the tectobulbar tract, which is responsible for the visio-protective reflex, which connects to the superior colliculus as well. Coming to the course, superficial origin, the trochlear nerve exits out of the nucleus, turns laterally, dorsally and winds the periaqueductal grey matter and decussate at the anterior medullary velum. From the side of the frenulum veli at the inferior colliculus level, it winds round the midbrain, the basis pedunculi or the crus cerebri, and then passes between the posterior cerebral artery and superior cerebellar artery and lateral to the posterior clinoid process enter into the cavernous sinus, where it is related above with the oculomotor nerve and below with the ophthalmic division of the trigeminal nerve, which is called as V1, and then enters into the orbit via the lateral compartment of the superior orbital fissure, and then it supplies the superior oblique muscle from its orbital surface. It is having communications in the cavernous sinus with the sympathetic plexus around the internal carotid artery, and in the superior orbital fissure it is communicating with the frontal nerve and the lacrimal nerve. The peculiarities of the trochlear nerve are: it is the only cranial nerve which is exiting from the dorsal aspect and has the true decussation of the nerve before it emerges from the brainstem. Coming to the clinical anatomy of the trochlear nerve, as it supplies the superior oblique muscle, whose functions are the depression of the eyeball, the intorsion of the eyeball, and the abduction of the eyeball. So, all these movements are lost. So, the eye appears up and in because of the loss of capability of abduction and depression. So, the trochlear nerve palsy presents with diplopia, which is mainly the vertical diplopia. So, the person with the trochlear nerve palsy has difficulty in walking down the stairs and inability to rotate the eye inferolaterally also. So, to compensate the vertical double vision, the person will tilt the head to the opposite direction with tucked in chin, so that the injured nerve is in extorted position because intorsion of this eyeball is lost because of the palsy to the superior oblique muscle. To compensate for the vertical double vision, with the tilting of the head to the opposite side, the axis of both eyes are maintained by intorsion of the normal eye, so that the double vision is compensated with the tilting of the head and tucked in chin. So, this fourth nerve palsy may be due to the diabetes and hypertension, aneurysm of the related vessels, which are mainly the posterior cerebral and superior cerebellar artery, where the nerve goes between these two vessels, and the berry-aneurysms of the posterior communicating artery as well. And cavernous sinus thrombosis also may result with the compression of the trochlear nerve, resulting in these symptoms. Coming to the summary of the fourth cranial nerve, the fourth cranial nerve nucleus is present at the level of inferior colliculus at the floor of the aqueduct, and it passes backwards, decussates at the anterior medullary velum, and then winds round the midbrain, the basis pedunculi, and in the interpeduncular fossa it passes between the posterior cerebral artery and the superior cerebellar artery, and lateral to the posterior clinoid process enters into the cavernous sinus placed in the lateral wall of the cavernous sinus related to the oculomotor nerve in front and the ophthalmic nerve behind, enters via the superior orbital fissure from its lateral compartment into the orbit, supplying the superior oblique muscle. Coming to the abducens nerve. The abducens nerve also is entirely a motor nerve which supplies lateral rectus muscle. It is the most vulnerable cranial nerve of the 3, 4, 6 cranial nerve to be damaged in the trauma involving cranium because it has a longest intracranial course. The functional components of the abducens nerve are having the somatic efferent fibers, which are again in line with the oculomotor nerve and the trochlear nerve, and is responsible for its supply to the lateral rectus, which has lateral movement of the eyeball. It also carries proprioceptive impulses from the lateral rectus to the mesencephalic nucleus of the fifth cranial nerve via the ophthalmic nerve, with its communication to the ophthalmic nerve within the orbit. The deep origin of the nerve. The nucleus of the abducens nerve is beneath the floor of the fourth ventricle and beneath the facial colliculus, which is formed by the internal genu of the seventh cranial nerve fibers, which wind round the nucleus of the abducens nerve. So, the placement of the abducent nucleus is in the floor of the fourth ventricle beneath the facial colliculus. The central connections of which are from the cerebral cortex bilaterally and is connected to the medial longitudinal fasciculus along with oculomotor, trochlear and the vestibulocochlear nerves, which altogether have the coordinated movements of the eyeball and is related to tectobulbar tract for the which connects the visual cortex and superior colliculus for visuoprotective reflex. It has connections with the para-abducent nucleus, where the para-abducent nucleus gives out most of the fibers of the abducent nucleus and is connected to the third and fourth cranial nerve via the medial longitudinal fasciculus for the coordinated ocular movements. The superficial origin of the abducent nerve. So, the abducent nerve passes forwards through the trapezoid body, the medial lemniscus and the basilar part of the pons. At the surface of the lower border of the pons, which is related to the pyramid of the medulla oblongata, it exits out and is in the cisterna pontis, where it is crossed by the anterior inferior cerebellar artery. Here it pierces the dura mater lateral to the dorsum cellae of the sphenoid. It crosses the upper border of the petrous temporal, almost at the apex of the petrous part of the temporal bone, below the petrosphenoid ligament, which forms a foramen which is called as Dorello's canal. So, it takes a sharp 90 degrees bend and then enters into the cavernous sinus, which is inferiolateral to the internal carotid artery. As it enters into the cavernous sinus, initially it is inferior lateral to the internal carotid artery, and then as it proceeds forwards, it is related inferolateral to the internal carotid artery in the cavernous sinus, and it enters the orbit through the tendinous ring of Zinn inferolateral to the inferior ramus of the oculomotor nerve and enters into the orbit and supplies the lateral rectus from its ocular surface at anterior 2/3 and the posterior 1/3 of the muzzle. The peculiarities of this nerve are, it changes its direction 3 times. Initially, it is downwards and forwards, and then as it has to cross through the apex, it will ascend upwards and laterally and then forwards. So, that is how it is changing its direction thrice, and it bends twice at the lower border of the pons and also at the upper border of the petrous temporal, that is corresponding to the apex of the petrous temporal, that is the Dorello's canal. Coming to the clinical anatomy, the sixth nerve palsy presents with medial squint and diplopia, that is double vision. So, here the medial squint is because of the unopposed action of the medial rectus, and the injured eye does not have capability of abduction. That is the very reason the eyeball is adducted, which gives the medial squint. And there is horizontal diplopia that is seen because there is double vision that is seen by both the eyeballs. So, to compensate this, the person always looks on to the opposite side to look at any object, so that he avoids the double vision. And this can be due to the sixth nerve palsy, can be due to brainstem syndrome. That is, during the intracranial pressure increase, there is the shift in the brainstem which causes its pressure over the sixth cranial nerve against the tentorium cerebelli. And as this nerve ascends over the clivus and turns 90 degrees to enter into the Dorello's canal, there it can be get compressed by the petroclinoid ligament, and that is where it is called as petrous apex syndrome. Since it is within the cavernous sinus, even there is any pathology with the cavernous sinus, this sixth cranial nerve can get compressed. And in the orbital syndromes, when there are any tumors in the orbit, also the sixth cranial nerve can get compressed along with the trauma. And of course, the diabetes and hypertension also leads to the damage to the sixth cranial nerve. So, when the nerve is damaged, the eyes are seen in. The eyes are in the sixth nerve palsy, which represents the medial squint along with double vision. And there is another clinical aspect for the sixth cranial nerve, which is called as Raymond syndrome, which consists of ipsilateral abducens impairment and contralateral hemiparesis because of the damage to the pontine branches of the basilar artery. So, when there is infarction of the basilar part of the pons, there is involvement of the sixth cranial nerve and the corticospinal fibers. That is the reason there is contralateral hemiparesis along with the medial squint and the diplopia. Coming to the summary of the sixth cranial nerve, the sixth cranial nerve emerges from the abducens nucleus, which is related to the floor of the fourth ventricle and the facial colliculus. So, it passes through the pons, crossing over the trapezoid body, medial lemniscus and the basilar part of the pons, and enters into cisterna pontis, where it is crossed by the anterior inferior cerebellar artery. From here, it ascends up on the clivus and takes a 90-degree bend at the apex of the petrous temporal, passing through the Dorello's canal, which is created by the petrosphenoid ligament, and then it enters into the cavernous sinus related laterally to the internal carotid artery initially, and as it courses forward, then it is related to the inferolateral to the internal carotid artery, enters through the tendinous ring of the Zinn of the superior orbital fissure, enters into the orbit to supply the lateral rectus.